chest, it indicates chest pain. So any pain which is more than pain in just in chest. So basically, it is a literature kind of thing when you perceive it. So any chest pain which is not simply a muscular, or it is something more, it has to be evaluated as a pain of corneal disease, basically more commonly pain of acute coronary syndrome. Now the H stands for high sensitivity troponins. So basically my next slides will be covering all these 10 commandments of approach to any patients of coronary artery disease. So this is the first thing. Any pain which is might be having accompanied with discomfort in chest, shoulders, arms, neck, back, upper abdomen, or jaw, or if it is associated with shortness of breath or fatigue. So these are the anginal equivalents. So these kind of chest pain, they should not be directly said to be a non-cardiac chest pain. Now, the second, the H of the chest, it stands for high sensitivity troponins. So, preferred if you are approaching a patient of acute coronary syndrome with coronary artery disease. So, basically, the troponin assay now, which is said to be better, is high sensitivity troponin. And the E of chest, it stands for early care of acute symptoms. So basically, whenever we perceive that no, it is an emergency, it looks like as a cardiac emergency, there should be no delay in calling the help. What we people from Bihar, especially Bihar and the eastern part of India, we try to negate our thoughts that no, this pain can't be pain of coronary artery disease or acute coronary syndrome. We generally think that it looks like a gas problem. So acceptance is an issue. The acceptance of any disease in our society is a major issue. And the issue with cardiac emergency is that the time is very important. So if you accept it as early as possible, then obviously you can get the better and most effective treatment, so that without any time lapse or without any myocardial damage, your treatment can be done. S of chest, it stands for shared decision making. So uh, a clinical stable patient, they should also be included in decision making. The adverse effect, radiation exposure, cost, alternative option, everything has to be discussed. It is not that if you get any patient, any every patient has to undergo an angiogram, every patient has to undergo a TMT, every patient has to undergo a highly sensitive troponin. You have to stratify. The decision making has to be a shared decision making. Now, the T of chest, it stands for testing is not needed routinely for low risk patients. So, whenever we see our patients of suspected coronary artery disease, so we have to stratify our patient into low risk group, intermediate risk group, and high risk group. So, those patients in the high risk group, they need urgent diagnostic testing so that their treatment can be done as early as possible. But if you get a patient of low risk score, suppose if I am getting a 40 years old, non-diabetic, non-hypertensive male. So basically he now falls in the low risk group. And if his pain is not typical, then we need not to undergo any kind of test in this patient. Even it is said that even ECG is not required also if you think that the pain is not typical at all. Now, different pathways we have to follow for acute coronary syndrome. We have different algorithm, different pathways which should be followed, which have to be followed on the emergency basis. And if we have stable patients, so they have outpatient pathway. We have specific flow charts dedicated to them. Now, the pain, A in the pain, it is accompanying symptoms. So, female and males have different kinds of accompanying symptoms. So, females usually have more these kind of symptoms such as nausea, shortness of breath, vomiting. These things can be present, especially in NPO or MI patients. Now, we have to identify that which patient is going to benefit from which kind of test. So, as a developing nation, it is not possible for us to offer all kind of tests to everyone. we have to stratify that which patient needs it most. So, as you all know that we follow a triage system in emergency, the same kind of triage we have to follow into ourselves while prescribing the investigation, while evaluating our patients of coronary artery disease. Now, we usually write in our prescriptions, even though I also feel sorry that infrequently I often write atypical chest pain. So atypical chest pain is now a misnomer. So atypical chest pain has not to be used. If we are sure that this pain is not of a coronary artery disease, then we should write non-cardiac chest pain. So atypical has not to be used. And finally, a structural risk assessment has to be done. Which patient has to be taken up first, or which patient has to be taken up last. So this is the index, how we stratify, how is the probability of ischemia. So if the pain is central, if it is associated with pressure, if it is squeezing in nature, then there is high probability of having a coronary artery disease. But if it is a sharp fleeting, and if it is migratory, or if it is localized, or if it looks positional, then obviously the risk of coronary artery disease is very low in these patients. Different kinds of chest pain causes have been stratified depending upon the age. This is a flow chart. This is a bar diagram which shows that which group presents with which kind of chest pain. So you can say non-specific chest pain, it's still the most commonly presenting symptom. Now, these are the characteristics. First of all, we have to know about the nature of the chest pain. So, anginal symptom usually they are retrosternal, associated with pain, discomfort, heaviness, and sharp chest pain increasing with inspiration or lying supine. It is unlikely due to coronary artery disease. And the second thing, we have to ask our patient about the onset of the duration. So, basically, a anginal pain, it is crescendo or decrescendo in nature. It develops over a few minutes. If it is a sudden onset, then obviously it is not a coronary disease, because suppose if there is a coronary artery occlusion, then obviously it takes some time for the myocardium to generate the signal so that the pain can be perceived. But if it is sudden ripping, then obviously some very deleterious thing has occurred very in a very short period of time. So most commonly it is aortic dissection which occurs with this rapidity. And if it is a fleeting, so unlikely it is a ischemic heart disease pain. Now, location and radiation, we all know if it is central or left-sided, and if it is radiating to left arm or umbilicus or optic jaw, it is usually due to myocardial ischemia. Now, how severe is the pain? So, basically, the pain of coronary disease, if it is stable, it is not that much severe. If it is if it is due to acute coronary syndrome, it is of intermediate grade. But if it is due to aortic dissection, it is severe. People often say that it is the worst chest pain of my life, which I have experienced. Now, how pain is precipitating? We have to ask. We have, because in during the examination and history taking of our patients, we should ask our patient that how your symptoms are precipitated. So usually, if it is due to coronary disease, so exertion is the most common precipitant. And if it is occurring at rest, or if it is with minimal exertion, so obviously that patient is going to fall under the group of acute coronary syndrome, unstable angina, non-ST elevation MI, or STEMI. Now, if it is positional, then obviously it is non-cardiac. How it is relieved? If it is relieved with rest, then obviously it is due to myocardial ischemia. If it is relieved with nitroglycerin, then obviously it is due to myocardial ischemia. If it is not relieved at rest, or if it is progressive, then obviously we have to rule out acute coronary syndrome too. Now, the how we physically examine some common things which can be seen in patients in emergency who present with ACS, such as diaphoresis, tachypnea, tachycardia, hypotension. If LV dysfunction has occurred, then obviously signs of left ventricular failure. S3 is heard, and murmur of mitral regurgitation or other mechanical complication if it has occurred. Now, the second emergency cause of chest pain is pulmonary embolism, but it is associated with dyspnea and tachycardia. The chest pain is not that much severe. If some time has passed on after pulmonary embolism, uh, then obviously due to irritation of the pleura, the inspiratory pain is there because pulmonary infarction leads to irritation of pleura. Now, aortic dissection, different things we can found the chest X-ray, the CT ratio is increased, differential pulses are seen in both the upper limbs, and esophageal rupture. So, emphysema, subcutaneous emphysema is the most common thing because after esophageal rupture, there is mediastinal emphysema which progresses to the subcutaneous space, and often it is associated with pneumothorax. Other causes are pericarditis, myocarditis. So these are the I can say that these are uh, the things which present as a pseudo coronary artery disease symptoms. And now this is the algorithm which has to be followed in emergency. So as per the history and physical examination, if we think that this pain can be due to coronary disease, then obviously the first thing which has to be done is to get an ECG done. After an ECG, first diagnosis which we have to make is whether it is ST elevation MI or not. If it is ST elevation MI, then we have to follow the STEMI guidelines and prepare the patient for primary angioplasty. Now, if diffuse ST elevation is there in all the leads and ST depression in AVR and V1, then obviously it is a sign of pericarditis because the territory cannot be localized. Now, if there is no ST elevation, then ST depression or any non on any other STT changes or T inversion new onset, which is usually, then it is due to a non-ST elevation ACS issue. Now, if we get a normal ECG, then usually it is a non-diagnostic. So, if we have high suspicion of no, this pain, we are getting a normal 12 lead ECG, but this pain, it seems more like a pain of ACS, acute coronary syndrome. So, we should also try to get the posterior leads, lead V7 to V9, because posterior wall myocardial infarction, it is often missed in normal usual ECGs. Now, the second thing, if we have still suspicion that this pain is of coronary disease, but we are getting a normal ECG, so it is not that if you get a normal ECG and you send these patients back home. We have to follow these patients. Serial ECGs has to be done. If there is a pain, persisting pain, then every 10 minutes we have to get an ECG, or usually we have to get an ECG to be repeated every half an hour to 2 hours. And if we get an arrhythmia, so arrhythmia specific guideline has to be followed. So this is the pyramid which has been postulated. We have to stratify our patient. We have to stratify the patient, which patient we are going to send for which kind of test. If asymptomatic, no testing is required. If our patients fall in low risk category, usually no testing, but we still think that we have to rule out. So in these kind of patient, we can go for coronary artery calcium scoring. So CT coronary angiogram is not needed. We just need to go for coronary calcium scoring or an ECG. Now, the main question is those patients with intermediate risk. Usually, it is said that intermediate risk patients should undergo non-invasive testing, functional testing, stress thallium, stress echo, stress MRI. These are kind of tests that can be performed with these patients. But if my patient fall in high risk group or a patient of acute coronary syndrome, then obviously I will go for anatomic testing. So these patients should undergo invasive coronary angiogram. If they are in intermediate risk group, they can undergo a CT coronary angiogram too. So this is the flow chart which has been postulated by American College of Cardiology. It has to be followed as per the STEMI guidelines. So we as a physicians, if we get any patient of STEMI, If it is in the window period, now earlier it was said that first 24 hours patient should be sent for primary angioplasty, but now it has been more lenient. Both the American as well as European. American are more in favor of getting a primary angioplasty done within 48 hours. They have extended the time period from 24 hours to 48 hours. Basically, that was the result of a very large trial, that was O trial, occluded artery trial. In that trial, they said that if you get a 100% occluded artery after 3 days, then you should get a functional testing done whether there is uh, uh, myocardial viability, or we should FDG-PET a cardiac MRI, so that we should know that whether myocardium is viable or not before intervening in these patients. But in this view, they said that so before 3 days, up till 2 days, patient still can have some benefit. Now, the second thing, if we suspect ACS patient, so this is the history and physical examination, then we have to rule out non-cardiac things. If we think it is a possible ACS, then after ECG, the first test we have to done is a high sensitive troponin. We have to uh, uh, go through the pathways which has been postulated for low risk, for intermediate risk, and for high risk. So obviously, most of the patients which we get, they are of intermediate or high risk, usually in emergency. Our low risk patient usually never visit emergencies. Even intermediate and high risk patients also visit on an average with a delay of 12 to 24 hours in our cardiac emergencies. So this is a flow chart for intermediate risk group. Those patients with no previous history of coronary disease. So basically, if we think that this patient is suspected, though, we can undergo a non-invasive test or a stress test, and we have to follow the guidelines as per that. So basically, this part is more to be discussed among the intervention cardiology group. Now, we were just talking about chest pain associated with coronary disease. So we have to also keep in mind the different differential diagnosis which present with chest pain. Usually they are non-cardiac. So pulmonary causes, the most commonly is the pulmonary embolism, and pulmonary embolism is a thing which has to be ruled out. Uh, up till my training knowledge and everything, what I was said and what I still follow is pulmonary embolism is not always a diagnosis of exclusion. It has to be a diagnosis of inclusion. We have to think about pulmonary embolism before diagnosing it. If we do not have in our mind about a pulmonary embolism, whenever we see a patient of dyspnea or syncope in emergency, then obviously we will not be able to diagnose. And to your surprise, pulmonary embolism is being diagnosed within 2 weeks, only in less than one third of patients. Now, the second common cause of non-cardiac chest pain is hemothorax, pneumothorax, pneumomediastinal pneumonia, bronchitis, pleural irritation, and malignancy. Gastrointestinal causes can also lead to epigastric pain and retrosternal pain, and they mimic the chest pain of coronary disease. So basically, most commonly it is due to cholecystitis, pancreatitis, hiatal hernia, GERD, which is our most commonly our patients say that. So the typical symptoms with GERD is that if you ask our patients that रात को लेते हैं तो सीने में जलन महसूस होता है, सो मोर देन 50 of the patients they will say that the chest pain usually occurs in supine position, at mostly at rest. Patients with esophageal spasm, because patients of esophageal spasm, they get their symptoms relieved by sublingual nitroglycerin. So these patients are the most commonly being diagnosed as a pain of coronary disease, and usually they undergo coronary angiogram. A normal angiogram is there, and esophageal spasm is diagnosed only after a gastroenterologist sees it. Now, the diseases of chest wall, they also have symptoms which pertain in similarity to symptoms of coronary disease. There are herpes. I have seen a patient who has undergone a coronary angiogram, and that patient was suffering from herpes zoster. So basically, a physical examination is very important, which has to be seen. It is not that you just ask the patient how is your symptom, and you order a patient a coronary angiogram, you order a patient for treadmill test. This has not to be followed. Now, the disease of cervical radiculopathy, breast disease. If we are encountering a patients of if we are encountering females, so if a female says a localized chest pain, left side, so we have to ask that female patient. So whether do you is your localized pain is also associated with some mass or a thing on palpation. So we can get surprises. If we get a 40-50 years female with left-sided chest pain, and we can diagnose with fibroadenoma or fibroadenosis in these patients. Costochondritis in younger patients in the age group of 15 to 30 years. This is the common presenting symptoms which patients usually present, but usually the pain of costochondritis is localized. It is associated with movement. It is associated with deep respiration. Now, the uh, other miscellaneous things are usually psychological. Panic disorder patient, they present with chest pain. Anxiety disorder, somatization, hypochondriosis, they also present with chest pain. Uh, the hyperventilation syndrome, carbon monoxide, there is a chest heaviness, chest tightness, which usually patients feel. Sarcoidosis, if the sarcoidosis is in active phase, so obviously due to inflammation, there is a finding of chest pain. Lead poisoning, intervertebral disc prolapse, thoracic outlet syndrome, these also present with chest pain. So basically, these are the important things which, as a physician's perspective, as a cardiologist perspective, we, every one of us should know. So I will be very happy if any one of you have some query of, or if any one of you want to add something to this approach of chest pain, to this approach of coronary disease.
There are some people who are asking questions. Should we take the questions in between? We can take one or two
Sure,
questions to make it little, yeah, interesting. Otherwise, they will all see. Uh,
sure.
somebody has asked, what is the role of aspirin in treating CAD? Can it completely replace intervention in non-affordable patients? So that's a good question actually, and it आप इसको आंसर करिए. No, it cannot replace, but yes, it can be very good in
So,
preventing things and treating, keeping the patients in follow-up. आप बताएं डॉक्टर शमशाद.
So basically, when there was no intervention in cardiology, the only thing which was available to us was aspirin.
Yes, definitely.
When we read in Harrison, when we read in Brownwall too, the first thing which has to be done whenever we suspect a patient of acute coronary syndrome is to give him a dose of 162 to 325 milligram of aspirin. This is the first thing which has to be done. So obviously, aspirin, it all started with aspirin, but it is not prudent to say that aspirin is a replacement for further advanced treatment options which has been available from long ago.
Yes, and if you're talking about non-affordable and you have a patient of acute coronary syndrome, at least you have to anticoagulate and then you have to try to thrombolyze. So these are all very good affordable options. So at least we can go till there. So that is the message of the whole talk which we are having, that CAD for all. This basic knowledge is for everybody who is there in periphery or treating poor patients also. Then
So one thing is very
yes.
important because by thought we are very much polar. We are in favor of aspirin. No, aspirin is the only thing. Interventional cardiology, they say that intervention is the only thing which has to be done. So ideal thing is that aspirin as well as intervention is the ideal approach. So we, this thing we have to follow.
Okay. Then he has also asked why calcium scoring is not used routinely for diagnostic. So, good question. And that he's aware of calcium score, that is also a very good thing. So, can you tell something about calcium score, Dr. Shamshad?
So calcium, what I said in my slides in between, that in my patients of low risk group, even in some patients of intermediate risk group, if I think, suppose I get a patient of 50-year-old female, who is just having hypertension. I think that pain, she's coming to me every time with pain. But still, I think that this is a non-cardiac chest pain. So what I can do, I can get an imaging done, or I can get an stress test done. Usually in females, stress tests are often
Can be false
uh,
positive.
undiagnostic, because they are
Hmm.
most of the time false positive in nearly 25 to 30% of the these female patients. So in that case, a calcium scoring is going to help. So everybody will be surprised that I have asked for calcium scoring in one of my professors who came to Medanta from my MBBS days. So she was very adamant. She was getting CT coronary angiogram done
Yes.
every 3 years, 4 years. But this time I said that no, ma'am, we are going to get only calcium scoring because your CT coronary angiogram is normal. It has been done twice. And your treadmill test is positive. It doesn't mean that you have coronary disease. So the calcium scoring of that lady, it came zero. So zero calcium scoring, it means at the age of 50, 60 years, if there is plaque, there then obviously there will be some calcium, because plaque deposition is a process which starts from the womb. It starts in the fetal life only.
Yes. So, in a nutshell, we can also say that calcium score can be done
So the
for ruling out,
cutoff mark,
and basically,
yeah.
yes, risk stratification is a better word. We can stratify your patients. You can also sometimes rule out if you're not willing to get a CT coronary angiography done, or the kidney function is abnormal. Then calcium score can also be used to rule out your suspicion of CAD. More of it in the guidelines, it is used for risk stratification. So, should we continue with the talk a little bit, then take more questions? Because
Yeah,
we are, hmm,
actually, I have completed my talk.
okay.
So
That
basically,
that's
all the
that's very
approaches,
good.
uh, what we have to follow, which is a standard, which has to be
Yes,
followed not only in Patna or Bihar, it has to be followed everywhere, all over the world,
yes,
whether physician, whether a cardiologist, whether a general practitioner is sitting in UK, US, or Europe.
everybody. Yes, definitely. So we can see Ajay sir. Ajay sir is here. Good
Hello.
morning,
Good
sir.
evening, sir.
Hello.
Good
Good
morning to him.
evening.
Good morning, sir.
Yeah. Samsad, this was a great talk.
Yes,
I
sir.
got a little late. So, and Shraddha, thank you very
Yes.
much on
Thank you,
behalf
sir.
of myself and the whole API team. I have a question. I have a question I want to ask Samsad. Like somebody has chest pain in periphery and somebody has done the ECG. And so what should we do? Because this whole program is directed towards the junior doctors, the residents, and those who are working in rural areas. Dr. Tiwari repeatedly told us that let us keep a talk which will help the rural doctors. So,
I think,
what
sir,
do
we
you
can
say?
repeat
Somebody
one
has chest
slide.
pain.
Dr. Shamshad,
Mm,
you can show that slide again, and then we'll revise that thing. Sir, he has shown it. We can just go over a revision with this answer. The ECG one, the first slide, second slide.
yeah, we have done the ECG. We have confirmed it.
Yes, sir.
Somebody is sitting in a very rural area. How to start?
So this
Hmm,
is the
this one.
first slide, which
Yes,
I
sir.
said that after history and physical examination,
Yeah, I've seen
ECG
this. I
is
was
the
there.
first thing
I
if we
was
are
there.
suspecting it is a case of coronary disease. So ECG, we have to stratify this ECG in five kinds, five types. If it is ST elevation MI, then obviously it's an emergency. If we have facility to thrombolyze that patient, and if that patient cannot be shifted to a catheter equipped center within 2 hours, then obviously that patient has to be thrombolyzed there if facilities allow.
Yeah.
Now, second is pericarditis.
I've seen
We
this
can,
slide. Thank you very
yeah.
much. I've seen this slide. My only submission is to you is what drug we should keep in a rural setting practitioner, like in a block who is working and that done the ECG and found out some changes. So what basic drug we should give it there only. Don't have to
So
wait for
basic
any
drug, the
answer.
most important thing is aspirin. The second
Yeah.
important thing is statin. And third important thing is clopidogrel. Usually, it is said that clopidogrel or P2Y12 inhibitor group of drugs should be given after getting coronary angiogram done. But it is not available in that area in next 2-3 hours. Then obviously our patient has to go for dual antiplatelet therapy. Now, the third thing which has to be kept over there is this, nitrates, sublingual nitrates, because they are the thing which can give a transient relief to the ongoing chest pain. The fourth thing, because morphine and fentanyl, it is commonly available at block levels, because block levels hospitals have their OTs. Block level hospitals now have anesthesia facilities, so it has to be kept. And the next thing which has to be kept over there is a thrombolytic agent. Now, the state government is providing free of cost streptokinase or even tenecteplase at government hospitals. So these are the things. Basically, a hub kind of practice has to suppose if a physician
Yeah,
is sitting at a block level
that is a
and
very correct
he
message.
thinks
Yeah.
that thrombolizing can be dangerous, he can discuss with a nearby cardiologist which is sitting over a nearby cardiac center, and he can take the patient under the confidence that he is getting the treatment done along with the discussion with the cardiologist. So, what I said that if it is taking time to shift that patient to a cath lab center, then obviously that treatment has to be started over there.
Yeah, Dr. Tiwari is there.
Sir,
Anand, Dr.
should
Tiwari is
every
there.
patient should be given oxygens? What is the role of oxygen in acute symptom?
So,
Ox-
oxygen, what I said that now the recommendation is not there that every patient of myocardial infarction has to be oxygenated. The
So very
reason
clear-cut
behind
message
this
Dr.
is
Samsad has given. Yeah.
oxygen is a thing which leads to coronary vasospasm if we more oxygenate our patients. So any patient with a saturation of less than 90% or 88% has to be given oxygen therapy in case of myocardial infarction, or any patient with air hunger or a saturation of less than 92% and signs and symptoms of dyspnea, they can be given oxygen therapy. Routinely, all patients of myocardial infarction should not be given oxygen therapy.
Dr. Shraddha, can you just give a summary of what Samsad has talked? So this is a very important message you're going to give, you and Samsad.
Yes,
Because
sir.
somebody sitting in periphery and practicing cardiology or not practicing, if he sees a patient of chest pain, what message you'd like to give? One,
Yes.
Dr. Samsad has given that 4 drugs has to be there, available with
Yes,
them.
sir. So my message will be that, sir, first diagnose, as we have already started. Take the history. If the chest pain seems to be cardiac, don't get alarmed. Many times we see that people get very anxious, get a cardiac patient here, we should not take this patient. Try to help, see the vitals, take the history, see the intensity of the chest pain. If you do not have an echo machine, you cannot, but you can, judge from ECG that, okay, some kind of cardiac problem is there. If you diagnose it as acute coronary syndrome by ECG, if it is a STEMI, try to refer the patient after giving this primary treatment. If you think that patient can get in time to a better hospital where he can get a primary PCI, because that is muscle saving technique, and LVEF can be improved. Otherwise, the patient will have a decrease in LVEF. So that is the first thing. If you are able to diagnose that it is an NSTEMI or unstable angina, and the patient's vitals are good, then try to treat the patient there after giving these treatments. And you can always heparinize and thrombolize the patient if it is a STEMI and the patient is not able to go forward, to a higher center. So this is all the messages there. And also learn how to find out, that this patient is unstable. If the chest pain is persistent, the vitals are dropping, there is a tachycardia, as he said, the saturation is low, then you can judge that this patient may deteriorate very quickly, and the MI or the ACS is involving a larger territory of the ventricle. And in these patients, be cautious and try to refer those patients.
Yeah. We have 3 new questions posted
Yes.
in the chat box. So one question is that according to ACS guideline, door in, door out time at our center, what if our center is PCI center, but actual time if it is more than 4 hours. So it is very important to have a code STEMI at your center. Uh, at our center, we have started it almost, and it's almost 1.5 years. That whenever patient of ST elevation MI comes to our center, code stream is announced. If his window period is 48 hours. So obviously, once a code stream is announced, any code is announced, then the time lag of shifting from one place to another, it is curtailed. Now, second thing, if any PCI capable center is taking 4 hours to do a PCI, then I think this should not be the ideal kind of approach which has to be followed by that center. It is said that if you think that your STEMI patient has a time lag of more than 2 hours to get his revascularization, to get his primary angioplasty, then obviously that patient has to be thrombolized. Most of the centers, even though they are cath lab equipped centers, but if they have single cardiologist or if they have only two cardiologists, and in the night time, if a patient is there and if that cardiologist have worked already for 24 hours, then it is quite difficult for him to come back every night to do primary angioplasty. So in those centers, facilitated PCI is usually done. They usually thrombolize the patient after arrival, and they then do an angiogram in next 12 to 24 hours. Now, the second patient is in CLD. Second question is in CLD patients, if deranged PTINR, how to manage ACS? So basically, ACS we give antiplatelets. So antiplatelets has nothing to do with PTINR, if because we are not giving VK, warfarin, or acetrom kind of drugs. So in these patients, ACS can be managed safely with this thing. We have to be cautious with the dose of statins in patients of CLD. The dose of statin has to be decreased because the excretion of statin will be altered. Another thing is which is superior, clopidogrel or ticagrelor, to give loading dose. So loading dose, clopidogrel, you can give it outside cath lab, but ticagrelor is still preferred. It has to be given in cath lab, because suppose I am going to do an angiogram, and if my patient is having critical left main disease, and I have to send him immediately for surgery. So, and if I have loaded that patient with ticagrelor, then obviously there will be very high bleeding during his CABG. And final question is for pain relief if morphine is not available. So morphine is not very easily available at any center. Fentanyl is a easily available thing which can be given in our patients. So I hope we have tried to cover most of the things uh, pertaining to approach for coronary artery disease for all the physicians. And the next question has come regarding role of enoxaparin. So the guidelines say that if you have diagnosed ACS, enoxaparin has to be given. It is usually 0.6 milligram subcutaneous twice a day. But in STEMI patients, it is said that you can give 0.3 milligram IV, slow IV, first dose. So over to
Anybody
Ajay sir
should,
and Dr. Shraddha,
yeah,
that
this
if
is a
you
very
can.
important message that you can keep injectable enoxaparin. I mean, it's always enoxaparin is injectable. So you keep it in your deck, and it can be given IV also. So periphery, you can have aspirin, you can have statin, you can have clopidogrel, you can have nitrate, and you can have enoxaparin also. And it can be given 0.3 milligram IV. That's a very important message which Dr. Samsad has given. So any other comment from Srida or anybody else? If none, then we can probably
Yes,
we
I
can
think,
conclude.
yeah, we have done
So
it quite
Samsad,
nicely, though we
pick
started
one or
late,
two
but we
messages
had a
and then we
fruitful
end.
discussion. Yes.
Yeah.
I think, sir, we have covered all the questions and all the basics as well, and it was quite a good discussion. So we thank you, Dr. Shamshad, for giving this excellent lecture and taking out time from his busy schedule. And we
So,
welcome all of you for the next session. Yes.
it's a sorry from my side too, because I was given a
Uh,
time of 7:30. I got free from cath lab quite late, and there were some technical issues
no, you have shown
regarding
them
my
a picture.
presentation.
You have shown them a picture of what is lying for them in future and what an interventional cardiologist they have to be up for everything. So with
So
this note,
basically,
yeah.
what I said that it was a quite long, busy day. I was there in the hospital from yesterday morning
Yes,
and
yes,
came back today evening. So, anyways, that is the life of a cardiologist. So, for a cardiologist, we have to deal with emergencies.
yes.
So,
So that's why we
everyone,
always
we have to
stress on
inspire
that.
ourselves.
Yes, yes, we are ready for that. So this is the important message, that time is muscle. That's why he is there sleeping in the cath lab to save that muscle. So from all the periphery doctors who are not who are outside the referral center, it becomes their duty to recognize acute coronary syndrome, and then recognize ST elevation MI, and to start primary treatment, and to refer the patients who actually need an intervention. So that will be the end of this class. See you all in the next class, next session.
Thank you. Good night, everyone.
Good night.
Can you announce that next class would be very important on bradycardia? How to approach? Samsad, can you announce it? The next
Uh,
class
uh,
will be on bradycardia.
okay, sir.
How to
So
approach.
next class from cardiology side, it will be dedicated to how to approach bradycardia from a physician's perspective. So basically, we will be discussing some part of electrophysiology too in that because we need to show all of you some interest regarding a patient who comes to you with bradycardia, how to approach it. ECG is not a single thing which has to be done. A lot of more things are not now available for these kind of patients.
Thank you very much. Thank you all.
Yes,
Thank
sir.
you,
Good
Samsad,
night.
and thank you, Shraddha. Wonderful.